Hi, everyone. Well, so much for coming. We're excited, real excited to learn from Dan today. I was just about to share a story with him, but I thought, well, I'll just use this as my intro story. Everyone in this room could probably, at least the older people in the room, could tell this story. So like all of you, my life was affected by injury, and I'm excited to learn to know what maybe I should have done back in the day. But I used to play basketball growing up a lot, and for lots of years never had a serious injury. And then I was a high school basketball coach down in Montgomery, Alabama. I was a teacher and a basketball coach, and I would play with the kids all the time. And it was the end of like my second year there, and we had this big event planned. It was the students in the school against the coaches, and it was like the entire community came, all the parents, all the families, all the like supporters of the community. The gym was packed, and we were talking a lot of trash in the weeks before. And then like literally the opening tip, someone tipped it, and I went to get the ball, and a kid dove into my knee and blew out my ACL like 3 seconds into the game. And so that was my personal ACL story, Dan. I'm sure everyone in this room could tell one. But for me, at least, that impacted me physically, mentally, emotionally, every way at an older age. So I can only imagine the work that all of you do with people is both physical, but also there are the other domains of the injury. So impressive to learn from you all, and especially excited today to learn from Dan about your work, especially as it relates to ACLs as part of your great lab team that you all do. Just amazing work. So thank you, Dan, for being with us, and we're excited to learn from you.
Sounds good. Thanks, Pete. Thanks for having me. Yeah, we'll talk a little bit more about, so Brian talked a few weeks ago, kind of introducing to the BIP lab and what we do there. So we'll talk a little bit more about the things that we've learned related to ACL injury from our research, and then kind of how we apply this on an individual level to the athletes we see. So first, checked off the first goal for today, which was to have a new longest title for any one of my presentations. But in our lab group knows I'm not great at brevity, so that's absolutely ridiculous. But I couldn't decide. What I wanted to title it. So there we go. This might be like the 10,000th ACL talk that's been given. So certainly not a new concept by any means. But the question I would ask is, why do we keep coming back to this? Why always the ACL? Well, here's the way I would see it, or the factors that I think relate to making this such a studied injury, an injury that continues to be very problematic for athletic populations. So first of all, very challenging to return to sport after these types of injuries. We've seen a lot of research from Claire Arden and some other groups as well that have really tried to break this down into not just people that return to sport, but do they return to the previous level of sport? And that's where you see a definite difference, where you see a much lower population that return to the same level, and that it can really take quite a while to return to that same level. You might get back to your sport within a year, but are you really at that same level of performance? A lot of the professional sports analysis that we have, the NFL and the NBA, really shows that maybe there's kind of like that year after the injury where your performance is substantially reduced compared to your uninjured peers. And it really takes kind of maybe a full 2 years to get back to your previous level of performance. The rehab is long, and it's ridiculously repetitive. Again, the current kind of timeline for return to sport is about 8 to 9 months. And so that's 8 to 9 months of some pretty consistent rehab efforts. And the types of neuromuscular deficits that people have after these injuries means that, yeah, you're kind of doing the same types of exercises, or at least the exercises targeting the same deficits for a very long period of time. We've worked with a number of our student athletes, people who undergo some different procedures, whether it's like a hip arthroscopy or a more simple knee procedure, and then having this injury and kind of saying like, wow, like I was not prepared for this, or kind of, I've been through surgeries before, I've been through the recoveries, and this is different. And so that is really challenging. And this maybe gets to more what you mentioned about the psychological aspects of it. We're learning more and more about the effects of injury, not just as a peripheral joint injury, but systemically. So there have been a lot of really interesting brain imaging type studies that have been occurring over the last few years. And we're seeing more and more that the brain actually reorganizes, or brain activity can change as a result of an ACL injury. ACL as a stabilizing structure to the knee also provides important sensory information to the brain. So when you're eliminating that component from the system, it's not just the structural stability, It's your brain being able to kind of respond to changes and execute motor commands. So, one of the challenges is kind of, hey, my body, it's not just that I have an injury and I have a lack of stability, my body doesn't work like it used to, right? Like I'm trying to get my leg or my knee to do these things and it feels different. It doesn't respond in the way that it did before, and that can be very challenging. And then last, long-term sequelae. So we know that any of these types of knee ligament injuries are associated with early osteoarthritis, with kind of early degenerative joint disease. It's unclear if it's the injury, if it's the surgery, if it's, how much of those factors are controllable, how much it's individual differences, but there's definitely something there. There's definitely kind of this pathway of knee ligament injury, subsequent injury, and then this early kind of arthritic joint that really impairs quality of life. So, all of those factors, I'd say, combine to, make this a very challenging injury, both to, sustain and to treat. And the interesting thing I would say is that we're not having less of these, right? We haven't really gotten any better at preventing these over time. It's not like we've had reduced ACL injury incidents in the last 10 or 20 years. The incidence is about the same, or just the overall numbers are higher because we have more people participating in the sport. So that's why the ACL. So we have learned some things throughout the years, and I'm going to again kind of describe what we've learned from our research and things going forward. But first, let's take a little step back. So September 31st, 1997, we have the San Francisco 49ers playing the Tampa Bay Buccaneers. The GOAT Jerry Rice is tackled via face, missed the injury, via face mask by Warren Sapp. Warren Sapp actually not only helped contribute to Jerry Rice's ACL tear in this game, he also gave Steve Young a concussion. So interesting game for Warren Sapp. But that was a ACL injury, and Jerry Rice, very well known for his work ethic and I would just say legendary work ethic and performance on the field, and certainly had goals of returning faster than people typically do. So my question would be, how long until Jerry Rice returned to play in an NFL game after his ACL injury and reconstruction? I mentioned the current time frame is about 9 months. So was it 4 months, 6 months, 9 months, or 12 months? No, it was 3.5 months. 3.5 months later, Jerry Rice returned to play on December 15th of the same year. So something like week 3 to week 15. Steve Young is back. Good to see he recovered from his concussion as well, or at least to play again. Playing the Denver Broncos on Monday Night Football, Rice goes in motion on this play and catches a touchdown. This is actually his 3rd catch of the game. So, appearing to be a successful return, or at least able to participate in an NFL game, which is pretty amazing. Obviously, everybody is very happy to see him back on the field. Rice jogs off, and that would be his last play of the year, because as he catches the ball and is tackled, he lands right there on his left knee, which was his surgical knee. So on this play, Jerry Rice sustained a patella fracture and then was out for the rest of the year. Okay. So, the question is, well, okay, patella fracture, was that related to the injury? And the team released a lot of statements saying, absolutely not. It was not related to the ACL injury. You can find all kinds of interesting information on this still. But the reality is that there are, a lot of factors that go into this process. So Jerry Rice had a bone patellar tendon bone graft. That is the standard of care for at least our athletes here and most athletes in contact sports, because it has good graft fixation. But the downside of that graft is you are actually taking a slight piece of the patella, as you can see kind of on the illustration on the left there, and that helps secure the graft. You actually take a slight bone plug from the patella to help secure the graft in its new position. So that gives you good graft security, but it also weakens the patella a little bit, because you're removing bone from the patella. So that's kind of the deal here is, even though you can do everything well, you can't necessarily cheat the body's natural healing rate. So that's definitely one of the things that we've learned over time, is really not to rush return to sport, that you just can't push things too fast. I would say 10 years ago, the going time frame for return to sport was 6 months. That was pretty much it across the board. you know, you maybe did some certain types of testing, or maybe you went and saw your surgeon and he looked at your knee and he said, you're good to play. But that was pretty much standard. And at the time that Rice had the injury and return to sport, it was kind of about how fast you could get people back. Like, how fast can we get back? You know, what's the soonest that you can get back on the field? Really pushing that side of things. And what we've learned is that, yeah, that's not necessarily great from a long-term standpoint. A lot of people were really suffering re-injuries in that early time frame. And we've learned that maybe 8-9 months is more appropriate for most of these types of injuries. So, as I mentioned, Brian gave us kind of the intro to the BAP lab and the types of assessments that we collect on our student athletes. So in relation to ACL injury and reconstruction, we have a large number of measures that we capture on these athletes. We do different types of strength and muscle performance tests. We do motion capture analysis of how they run and how they jump. And basically what we've learned from this is that the closer that you look at things, kind of the more you find, and maybe the more problems that you find, right? If you just were to, you know, watch someone run, hey, you can run fast, that's great. But when you really measure it, they may be running very abnormally or asymmetrically. Hey, you can jump high, but you may be landing almost entirely on your non-surgical leg. You may be strong, but you may not be quick or powerful. So that's kind of the strategy that we take, is to try to look closely at everything and see where everyone's deficits lie and try to, let's say, address those modifiable factors as best we can. So just real quick, this is kind of what I just described. I'm certainly not going to go through this in too much depth, but this is kind of describes our current testing protocol for our athletes who are recovering from these injuries and surgeries. So things start out with kind of some sub-maximal assessments early on to track recovery and just try to find any kind of red flags there, any things where people are really lagging behind. And then going forward, we get into our more standard testing protocol about 4 months post-surgery, where we really do this larger battery of tests. So I'm going to talk a little bit about some of the things that we've learned from these assessments from a research standpoint, and then again, kind of how we apply this from more of a treatment standpoint. So this is some of our research findings on running mechanics after ACL injury and reconstruction. And the triangle in the middle of this graphic is a radar plot. Basically what it's showing is the knee, hip, and ankle joint torques during running, treadmill running in our athletes. And so basically what we see is that 6, 9, and 13 months post-surgery, most of our athletes are asymmetrical. In fact, at 13 months post-surgery, the average knee extensor symmetry is about 75%, and the hip extensor symmetry is about 110%. So the way that most of these athletes are running is they're shifting load from the knee to the hip. They're unable to load the involved limb the same way that they can load their healthy limb when they're running. In fact, I would say it's only about 3, I think this is a group of 17 athletes that the data is from, and I want to say it's only 3 out of the 17 that were symmetrical at all 3 joints. So here's kind of big take home, what we've learned. Most athletes run with abnormal knee mechanics greater than 1 year post-surgery. So what? Well, this may reduce athletic performance and impair long-term joint health. This one, kind of unclear. This one definitely we're more concerned about. The idea that if you're loading abnormally, are you contributing to that OA or the kind of the early joint degeneration? Okay, on to some of the strength or muscle performance research. We do a lot of assessments of quadriceps muscle performance. The quadriceps is your anterior thigh muscle. It's the largest muscle group in the body. It is very significantly affected by knee joint injury and surgery. Remember how difficult it is to fire your quadriceps muscle after the surgery, right? And this is an example of an athlete after the surgery. It almost looks like the quad is gone on the involved side, right? You have significant atrophy, significant problems with it. And that's one of the things that really impairs recovery after this injury. So on the left is our quadriceps strength results in 25 of our University of Wisconsin student athletes at 4, 6, and 12 months. By about 1 year post-surgery, the average limb symmetry in the group is about 90%. That's about normal. normal between them variation is about 10%. So they're right at that edge of normal. I'd like to see kind of the whole group a little bit closer to that, but it's pretty close. However, it's not just strength that we're interested in. When we ask people to try to produce force quickly, we see some very different results. We think this is important because these are athletes. They have to move quickly in their sport. They have to generate forces quickly to be able to accelerate, decelerate, jump, stop, whatever it is. So when we assess I'm calling it power here, just for simplicity's sake, but when we assess the quadriceps power, we see some very different results. Now at even a year post-surgery, on the group level, we're less than 75% symmetry, and only about 5 of our 25 athletes have reached that goal 90% at that time. So, and sorry, I forgot this slide. In addition, we've also learned that quadriceps power measure may relate more closely to how people move than the strength measure. So kind of across the board, I talked about the running knee kinetics first. If you have worse quadriceps power, you're likely to have worse running mechanics. And strength, the findings are just a little bit less closely associated. So ultimately what we've learned, quadriceps power is more impaired than strength, and we think that's very important for athletic movement after this surgery. And therefore, we should emphasize rapid and powerful quadriceps exercise in our post-operative rehab, right? That should be something that we either try to institute earlier or try to make sure is a focus of the program throughout the recovery process. Moving on to a little bit different investigation. This was something that we did a few years ago, and a lot of groups have done this as well, but this was our version of it with our own student athletes, is looked at how this ACL injury influences future injury. So what we did was looked at, I want to say we had over 50 athletes in this group, but looked at their injury rate 1 year before their ACL injury, and then 1 year after their return to sport. So you're comparing pre and post in the same student athletes. Basically what we found is that there's a higher rate of injury in the year after those athletes return to sport, and the time loss for those injuries was greater. So essentially the injuries may be more severe is the idea. So that's, again, just kind of important information, right, from the standpoint of what does the ACL injury and the surgery mean for an athlete's career. High-level athletic careers are short, right, as they are. And so we need to be kind of looking forward and seeing how we can maintain health and wellness going forward. So basically what we learned after this injury and surgery, collegiate athletes have a greater risk of injury and greater severity of injury. And so we need to try to address all the modifiable factors that we can to maximize successful return to sport. Last one that falls under this group of kind of what we've learned. So I mentioned doing our quadriceps muscle assessments. We want to look at strength, we want to look at power. Basically, when we strap an athlete's leg to our testing system here, to our isokinetic dynamometer, we're going to ask them to try to extend their knee, and that's how we're kind of measuring their quadriceps muscle function. So we can see how strong they are or how much torque they produce. And we can also look at their muscle activation patterns. So those little sensors on that athlete's thigh are EMG sensors, and those allow us to record the electrical activity of the muscle. So basically, it tells us a little bit more about some of the neural aspects. Can the brain fire the muscle? Can the brain control the muscle? So what we see on the left there is basically a graphic of both the torque and the EMG as an individual is trying to kick. But not everybody's torque and EMG looks like that. So for some of our student athletes who are post ACL reconstruction, we may ask them to kick and actually see that their leg kind of vibrates or shakes as they try to kick. What happens there, what that produces is a torque and muscle activity data that looks like this. And that's a very different looking torque curve and muscle activation curve than what we see on the left. Basically what we see is we see this unsteadiness. They're not trying to do that. They're not trying to shake their leg. It's just the reality of that person not being able to fire their muscle consistently. So this is kind of, again, something that others have noticed as well, but we've really tried to, I'll say, break this down and put a number on it, try to characterize how severe this is in some of our athletes. And it can be very problematic in terms of the rate of recovery. Basically, the greater level of dysfunction you have here, the slower your recovery may be. So for things we've learned, torque steadiness is impaired post ACL reconstruction and is related to that neuromuscular dysfunction. And then kind of the larger take-home point, just looking at what it looks like when someone kicks, just looking at the force or torque that's generated can give us valuable information about the muscle function. So even if you don't have maybe the ability to analyze the muscle activation patterns that we do, you could ask someone to try to kick and hold, and if they really are shaking as they're doing that, they're probably really impaired in terms of their neuromuscular function. So again, now I want to kind of bring it back to the idea of individualized treatment. So those are all kind of our bigger picture research findings, and yeah, that's kind of how it's done, right? We're synthesizing information across a larger number of student athletes, whether it's 20, 25, whatever we have in a given group. But on the individual level, we don't necessarily, there's some value to applying those larger principles, but we can do better than that, right? We want to be more individual with our prescription and our recommendations. So here's a few examples of that. So I have data here from 2 different athletes that are 6 months post ACL reconstruction. So here's athlete 1 on the left, athlete 2 on the right. Both have about 50% quad strength symmetry. So both have notable quad weakness. Okay? We already said quad muscle weakness, that's important, it's a problem. Okay? But obviously our athlete on the right here has a different torque time curve and a different muscle activation pattern than the athlete on the left, right? This is someone who has that unsteadiness in their torque curve and this different neuromuscular activation pattern. So the take home is like, both these athletes are same time frame post-surgery, same strength deficit, but they're not the same. We shouldn't treat these athletes exactly the same because they will recover differently and really they kind of need or would benefit from different types of exercises or would, let's say, stand to benefit the most from different types of exercises. But if we didn't assess this, we wouldn't know, right? If we just looked at time from surgery, oh, they're both 6 months, they should be doing the same types of things. Or even if we just looked at strength, oh, they're both about the same, about the same strength. You should be doing these types of exercises. But when we look a little bit deeper, then we can really kind of tease out some of these individual differences. So one example here of a men's soccer player that we had who was 5 months post ACL reconstruction. Here are his torque time curves as we try to assess his quadriceps muscle strength. Okay? So what we do is look at the maximal torque that he can generate on each limb. And basically what we see is that at 5 months post-surgery, this athlete has almost 90% strength symmetry. That's great. That's actually better than what we typically see at that time frame, right? He's actually kind of ahead of the curve in that regard. Okay. However, when we ask the athlete to try to kick quickly and to try to generate force quickly, we see a very different picture. This athlete cannot generate force on the involved limb or quadriceps force as quickly as they can on the uninvolved limb. So now we only see a symmetry or a limb symmetry of about 50%. And sorry, not to go too far into this, but basically what we're doing is just looking at the slope of each of these lines now instead of the very top, the very peak that we're seeing. So if we're doing it by slope and we're looking at the muscle activation pattern, this is a very different picture, right? This wouldn't necessarily, this does not fit in the desired ranges, right? It's not at the goal levels for these type of metrics. And maybe unsurprisingly, this athlete at this point in time, was not running and jumping with very symmetrical movement patterns, with very symmetrical movement. So again, if we had just done this from a strength standpoint, it looks like the athlete's doing great, but when we do this type of evaluation, things are a little bit different. So these are the types of exercises that were prescribed to this athlete. Okay? A forward lunge, but with a very rapid pushback to standing. So the idea of trying to fire the muscle very quickly. Okay? Doing a seated knee extension exercise with the same idea, increasing the load as he's doing this, but trying to move quickly from the very start of the contraction, trying to activate the muscle quickly. Same thing with the leg press setup. Again, this is the heavier load, so it doesn't look like he's moving all that fast because the load's pretty heavy, but it doesn't matter. As long as he's trying to move quickly, that will train the system to be able to fire more rapidly. So after about 3 months of this type of training, we see significant improvements in his rate-based measures. So this was essentially the end result after 3 months of this type of training. That slope that we saw improved by about 30%. He could fire the muscle very quickly at the start of a contraction, and he moved more symmetrically. Okay? So again, a little bit more on the individual level, that was what this athlete needed. One more example, let's look at some of this unsteadiness data. Okay, so this is more related to some other treatment that we can use to try to stimulate muscle and to try to smooth out some of these torque time curves. So this was an athlete, again, when they were trying to do a knee extension contraction, had a lot of vibration there, had, let's say, a very abnormal muscle activation pattern. The problem with this situation, just saying, oh, just strengthen it, like do a strengthening exercise, is the brain's not fully activating the muscle, so you won't respond, the body won't respond very well to a regular strengthening exercise. You will make very, let's say, slow strength gains until this resolves. So the number one goal for a patient like this is to try to get more consistent activation or use some other strategies to try to increase load during rehabilitation. So what we're going to do for this patient, or what we recommended, is to add muscle stimulation to some of that patient's voluntary exercises. So basically what this is actually providing an electrical stimulus directly to the muscle. So we're using these little muscle stimulation units and placing some electrode pads over the quadriceps and having the athlete do exercises with concurrent stimulation. So those types of exercises look like this. Basically trying to fire that muscle continuously with some load on the leg with concurrent stimulation. Trying to hold a position. Right? The athlete can't necessarily contract and hold, so we're trying to hold the position, providing the stimulation with that type of balance exercise. And then even an exercise like a leg press, we can really increase the load. If we're adding a lot of stimulation to the muscle, they might be able to tolerate a much higher load, and that will give us a greater or a faster recovery. So for this individual, even, and normally the changes aren't necessarily this fast. This is kind of a great example of this. But just 1 month after really instituting this type of regular neuromuscular stimulation treatment, we saw a 43% increase in involvement strength and a notable increase in muscle activation of the quadriceps. And you can see, I mean, it's not perfect. It doesn't completely get rid of that unsteadiness in the torque curve, but it's substantially improved. And that's about the best rate of improvement that you can hope for within that time frame. So again, that's an example of, from that standpoint, the type of treatment that we can try to provide and make things more individualized for our athletes. And there's many examples of this, right? I just showed a few. There are athletes that we have who have bilateral weakness, right? So it's not necessarily that they may have some asymmetry, but both legs are really weak. Well, that's also a problem. That's a very different presentation than what we've seen here. That athlete should absolutely be doing strengthening exercises with both legs. We see athletes where they've got good muscle performance recovery, but they still move abnormally. Well, then they need to do more motor control training, whether it's running retraining or some other kinds of consistent feedback during their functional activities to help them build their leg. So lots of examples, but again, that's kind of how we want to use the data from an individualized perspective. Now, I do not mean to frame this as, so far we kind of just looked at a lot of negative aspects, right? Like that, I know everybody is, re-injury rate is high and people are really real struggle after these injuries. I do want to be clear, most people do successfully return to sport, right? It's not that 20% return to sport. Even in some of those studies from Claire Ardern, it's usually like 60 to 85% are returning to the previous level. So that is most people. Recent examples, right, that we've seen. To watch the Super Bowl this year, Cooper Kupp was the best wide receiver in the NFL this year, at least statistically, and is 2.5 years removed from his ACL injury and reconstruction. Quarterback for the other team was Joe Burrow, who was less than 1 year post ACL reconstruction, which he suffered in I want to say like halfway through the season of his rookie year. And again, certainly had a better year than he did during his rookie year by all accounts, leading his team to the Super Bowl. Zach Levine is a particularly athletic shooting guard for the Chicago Bulls. Interesting thing about his profile is his injury was suffered kind of, he really is, I'd say, more of a star at this point. I think he was an all-star this last year, but really before that point. And actually his performance based on all the metrics that we have has only improved since his ACL injury and reconstruction, and has maintained his athleticism. This is Abby Steiner, who's a sprinter for Kentucky, who just set the Wisconsin women's collegiate record for the 200 meter, and has a history of ACL reconstruction. I want to say hers was in high school, so a few years before this, but used to be a dual sport athlete before playing soccer. So again, most people do successfully return to sport, and many, are able to perform at a very high level. The question is on the other side of things, right? How many people never really return, or let's say suffer a secondary injury or a recurrent injury, and we don't really know that they didn't, let's say, reach their potential, right? Like that's kind of hard to determine. There are cases like this, where we can all kind of see that he's not the same after the injury. But for every case like that, there may be many where, it's again, suffered as a collegiate athlete or as a high school athlete. And they're never really back to that same level of performance or athleticism or whatever it is. And yeah, that's hard to say. I'm not really sure what the percentages are there, but it's definitely the case, right? That there are a lot of people who don't seem to quite get back to the same level. And so, we're always trying to learn kind of information presented previously about this, what we can do about it to try to help people return as best they can. So I'd say in summary, the research that we do, but not just us, that many other groups do, continues to build on the existing knowledge that we have and try to advance our understanding of the body's response to these types of injuries and surgeries. So again, we're kind of always trying to add to that knowledge base and revise it. Sometimes it is things that we previously thought to be the case were not the case, right? We were trying to rush people back to sport and learn, hey, that's probably not the best plan. We should at least push back or pull back a little bit in terms of the rate there. But on the individual level, we can't forget that. We gotta, keep the individual student athlete in mind. And so we really need to try to analyze things on an individual level as well to provide that specific treatment that each athlete needs, and not necessarily treat people on a group level in that regard. So questions I have, and I'm sure most of these are, well, some of these are unanswerable, but I don't know if maybe substantive discussion or anything like that, but questions I have are, why do some people suffer secondary ACL tears even after they have excellent recovery of all objective performance measures? So we try to track all those aspects of recovery and say, okay, you meet all these criteria, you wait this long to return to sport, your re-injury risk is going to drop substantially. Great. But I can picture individual athletes that I've worked with where it was like, you've done everything. Like, you've checked all the boxes. We've done everything we can from a modifiable perspective, and you still get re-injured, right? And I don't know why that is. And I'm not sure that we can define why that is. I mean, certainly, hopefully going forward, there's the things that are maybe genetic factors or whatever that are part of the process that we don't currently analyze or don't really have a way of analyzing. But that's hard, right? That's very difficult from that perspective when you say, hey, you did everything you could, or I did everything I could, and still got re-injured. That could be very, difficult from an experience perspective. 2 would be, what are the long-term effects of returning to competitive sport after ACL reconstruction? We've seen more of this. Keith Kinner from our group is starting to kind of venture into this area a little bit more. But the idea that, if you return to sports after this, right, if the goal is like, I'm going to return to high-level sport, are you setting yourself up for some long-term knee issues later in life? I don't know, right? We don't really know. But that's kind of the question, right? Is, does having the injury period lead down a certain road, or how much what you do after that changes your long-term outcomes? And then, what are things going to look like in 10 or 20 years? Very interesting to think about what things are going to look like. Are we going to have better repair techniques? I certainly kind of hope so. There's been a lot of new work on not just ACL reconstruction, so not using a graft to just replace the torn graft, but actually trying to repair the existing graft. There are techniques that are in development for that type of thing. Can we use biologics for healing to facilitate more complete or rapid recovery? Very interesting research in animal models, obviously, that where this can be done, where if you do some different kind of manipulation after the initial injury, you may be able to prevent some of that muscle loss or some of those initial neuromuscular changes that take place. And then can we actually condition the ligament itself? Are there training protocols or other things we could do to like strengthen the ACL itself to prevent injury? Most of the injury prevention programs that currently exist are like trying to teach people to move differently, right? Like to land softly, or to not to land with your pelvis position or whatever it is, and to change the way people move. But if we could do this type of thing, if we could actually strengthen the ligament itself and prevent injury, yeah, that might actually be a more effective way of handling that. So anyway, that's kind of, those are some of the questions I have and thoughts going forward. But that's kind of all I had for you here today. I'm happy to answer any questions or any thoughts for discussion.
Thank you, Dan. We could ask questions. Dan, I had a question about, you had the one, the after injury where you had the triangle of like ankle, hip, knee, and you said that like knee mechanics often were not where they needed to be, or others. How much of that, I think you got it in the last question you asked, how much of that is also a cause of the injury? Like, so I know you all like do assessment of like how people run and move. And so the first part is, how much do those like asymmetries or whatever cause injury? And then the second part is like, do you see trends? I've always seen data on like certain sports of higher incidence of ACL or whatever. Are there like micro trends within sports that we can be attuned to in preventative ways?
That's the preventative thing is a tough question for sure. I'll start with the first one, the idea of it, that's an injury, a risky pattern. So to kind of simplify it, one way you could think about it is those individuals that are running, when they're loading their involved limb, they're not flexing their knee as much. They may be in a slightly more extended knee position or straighter knee position. So doing that during overground running, like treadmill running, that in itself is not a risk for injury or a risk for ACL injury, right? You're not going to tear your ACL doing straight line running over level ground. But if you're not flexing, if you're not bending your knee when you're running, we can reasonably surmise that you're also not bending your knee as much when you're landing, when you're cutting, when you're decelerating or pivoting. And those are all risk factors for ACL injury. So landing in a more extended position, landing or pushing off the knee in a more extended position is absolutely a risk factor for injury. So that's kind of the idea, right? That's a way we can certainly measure it when you're doing that task, but it does have implications beyond just how they run. It does have implications for their other movement patterns as well. Trends within sport. People have looked at things like fatigue. Like, are people more likely to tear their ACLs in the fourth quarter or whatever versus the first quarter? Not at all. Actually, the opposite is true. That from an ACL injury standpoint, I can't say this for all injury, but from an ACL injury standpoint, higher injury incidence is either at the start of the game or it's the same throughout. And actually, the idea is because people are less fatigued at the start of the game, the forces are higher. So the potential for that type of injury where you need a very, very high force is actually potentially greater at the start of the game. When people may be less fatigued. But other trends, like by position, yeah, I mean, we do see, for a sport like football, where there is quite a bit of a difference between positions. There certainly is differences in risk of ACL injury across positions there. Just not sure how, like, from a prevention standpoint, right? There's much to do with that. We can monitor all those things or kind of characterize all those things, but there just hasn't been. The prevention strategies are just, they are what they are. They're somewhat limited, and it's unlikely to have much of an impact in that type of situation.
Question. Have you looked at how, for athletes who tear their ACL, is it usually in conjunction with like some sort of other tear within the knee, or are there correlations there or causation or anything? I guess I'm just curious.
So if you're saying at the time of injury, like when the injury occurs,
and then like what impact does that have on recovery?
So like the Jerry Rice example, he tore his ACL, MCL, which is the medial collateral ligament on the inside of the knee, and I think he had a little bit of a meniscus tear as well. That's very common. That's a very common injury pattern to have those three ligaments or those two ligaments and some meniscus damage. Same as Tom Brady's injury. That what we've seen is a little bit more damage doesn't really change your outcomes. Like the MCL tends to heal on its own pretty well. A slight meniscus tear where maybe just removing a very small amount of tissue or something that can be sutured back together doesn't change your outcomes too much. If you start getting multiple ligaments into it, like MCL, ACL, and LCL, or one of the collateral ligaments is torn to the point that you need a graft for that as well, then that's a different situation. A multi-ligament injury in that regard is much more unstable. The joint is much more unstable, and that's a much worse outcome. From a long-term standpoint, if you have a meniscus tear, which is the cartilage, between the two long bones in the leg, that can't be repaired, and they have to remove a lot of meniscus. That's not so much from a short-term standpoint, but from a long-term standpoint, that's also much worse. That is what we think tends to really potentially predispose you to that OA or that early joint degeneration.
When we're looking at the neuromuscular pieces of the quadriceps, using that information then to identify an issue that then needs for care of the rehab, you make the case that let's just get everybody calling it really early on to try to prevent some of these things.
Absolutely, right? Like I do, right, and that's kind of the bigger picture thing. So the thing I didn't necessarily state with that athlete, that person at the time we evaluated him was like 6.5 months post-surgery. So that's quite a bit later. Like that NMES, this muscle stimulation, is typically used for most people, but very early after surgery. So that was certainly someone who kind of at that point, again, if we had just done this by time or whatever, would be getting a very different treatment. But because of that specific deficit, should have been using that specifically at that point. So working backwards, if we were able to either pre-surgery get people to a certain level and then kind of maintain that through that early post-surgical period. I mean, yeah, ideally, nobody would end up there. But also, there's definitely variation in that inhibition, and it's hard to explain why one person has substantially more inhibition than somebody else does at 4 or 6 months post-surgery. So I think the thought of showing that was like, we can say all we want about like what we should have done. At that point, it is what it is. Just kind of like, what can we do from that point? This would be the best from that standpoint. So, yeah.
This may be a question, like, I don't know, for you or for the broader group, is like, you indicated that the incidences of ACLs are not necessarily, of ACL tears, haven't changed a whole lot over time. And it relates to all the stuff we're talking about now. Are there any kind of major common injuries in the broader field of orthopedics that we have seen major, like, diminishment of those types of injuries? And if there are, like, I don't know, like Achilles or other whatever injuries in it, why was the broader field able to like make progress there versus not here?
Oh, this is a good question. So one of the things I'll state is that not only is ACL injury not decreasing, in the literature, if we're looking at the numbers, it may actually be increasing, but the thought there is at least a big portion of it, maybe just that we're better at detecting these things, recording them, whatever else it is. So I think across all injuries, that certainly can be the case, right? You do have that aspect of it, like, are we better at diagnosing things and actually calling it what it is or whatever? And that kind of appears to be a much higher rate over time, but maybe it's just better characterization or recognition of the injury. But as far as like specific injuries that we've made, a lot of progress in terms of preventing. Struggling to think of specifics. Anyone?
Yeah, I think primary prevention, I'm not sure we're much better at any of the injuries in primary prevention. First instance. But in terms of secondary prevention,
Yeah, that's good.
Ankle sprains, I think we've gotten a lot better at. That's one. I think part of it is because there are so many of those injuries, and they're a little bit more straightforward to study, and we have nationally and internationally incredible data set where you can start to see some of those. ACLs, really, when you think about that in particular, it's a high price tag injury, but it's not a very common injury. When you think about the number of injuries, right? Ankle sprains are extremely common. So there's a large data set to study that. there are a lot of the smaller, the bigger injuries like an ACL, like a knee dislocation, like a major hip injury. They're rare enough. We just don't have that critical mass of information.
And I don't know if it was someone else's presentation. It may have been David Bell or someone when he was talking about the tendencies toward earlier specialization or highly specialized on some impact type injuries. Are you able to attribute any increases or at least maintenance of levels to that in addition to being able to assess better?
So I'm not sure I've seen anything like really specific to sport specialization in these injuries or a real strong line there. The way I would look at it is it's just exposure. It's just more time.
Yeah.
Like soccer, we talked about that before I started. Like that's a high risk sport for ACL injury. So every time you play a game, like you have a risk, right? Well, over time, if you play 20 games, then this is your risk. If you're playing 100 games, then your overall, your absolute risk is going to increase. So if we're talking like from a youth sports standpoint, it may just be the total time in competition. We know that injury rates are always higher in competition than practice as well. So if a lot of these youth sports, if it's more, leagues and whatever, where it's always competition versus like off-season practice and then competition, that can also be a factor contributing to the higher rates. Yeah. Brian made a great point. I mean, I will add to that, like even from an ACL standpoint, like we are better at preventing secondary ACL injury. Like all the research that we have shows that if you do check all those boxes and address all the modifiable factors and wait the appropriate amount of time, you do have a reduced re-injury risk. So there is that. It's not all of them, but you do have a reduced re-injury risk. But yeah, primary is different. The first one is different.
Is there any of the neurological research with like the remodeling? Is anyone looking at links between the degree to re-injury rates or like psychological outlook on rehab and re-injury rates?
So yeah, so those are kind of two different. So when you're saying the first question, that's more like the brain function. Yeah, so I'll say it this way, that's kind of in its infancy. Like the way I look at it is, the articles that have done that usually have relatively small sample sizes. And they say like, hey, this is really interesting. In the people who post ACL, they have a lot more activity in these regions of the brain. Or, a simple movement pattern requires quite a bit more brain activity than it does in this person. Or if you restrict the vision, they have to have more brain activity to move than this person does. So I'm not sure I've seen like those kind of trends yet across the group where they have like large enough numbers yet to really look at that. That's just kind of starting from that perspective. From the psychological aspect, absolutely, there's a lot more out there on that. That has been a focus of ACL research for some groups for a long period of time. But it does go back to kind of the same question of what do you do about that? It's not this type of intervention. It should be a very different type of intervention, but more tailored to the individual, whether that's counseling, sports psychology, mindfulness training, something of that sort. But there have been some promising results with that type of training as well.
Super interesting. Thank you so much, Dan. I really appreciate it. It was
Yeah.
great. Thank you.